Thank you, everybody, for joining us. We're very exciting to co-host this webinar today. This webinar is being co-hosted by Women Deliver and Women in Global Health. And the reason for us wanting to put on a webinar today on global health security is very simple. Women make up 70% of the global health workforce and are the front line of health emergencies, including the unprecedented COVID-19 pandemic. In order for health workers to fully deliver health care to all within and beyond emergencies, their health, safety, and rights must be front and center. This discussion will feature health workers and advocates highlighting the critical role of women in the health workforce during COVID-19 and beyond. Speakers will share their experiences and perspectives on a people-centric and human rights-based approach to health security that is focused on delivering health for all through stronger health systems, proper equipped and financed health workforce, and responding to health crises while maintaining core women's health services. Our speakers will also highlight recommendations and actions to propel advocacy to support investments in and commitments to women in the health workforce. My name is Dr. Monica Sunday. I'm the co-chair of the Gender Equity Hub at Women in Global Health. And joining me behind the scenes is Darcy Allen, Senior Associate and Policy Advocate at Women Deliver. So without further ado, I'm going to go ahead and introduce our first speaker. Our first speaker is Sarah Hillware. Sarah is an award-winning social entrepreneur and global communications strategist. She currently works as the Deputy Director at Women in Global Health. She also acts as a consultant to specialized UN agencies, often working at the intersection of international development communications and project operations to drive global action and national policy reform. Sarah's expertise on school and community-based health communications interventions and global women's issues has led her to speaking opportunities at TEDx Berkeley and TEDx UN Plaza. Sarah, the floor is yours.
Thank you, Monia, for the introduction, and good morning and good afternoon to everyone. It's great to be here. I recently joined the Women in Global Health team, and really looking forward to our discussion today. So just to open up, want to of course thank Women Deliver for co-hosting with us today. Women Deliver is a member of the Gender Equity Hub, which Women in Global Health co-chairs with the World Health Organization. And this hub was started in 2017 to highlight issues surrounding health workforce and gender equity. This morning, want to talk with you all about the issues surrounding gender equity and health workforce. But first, just want to give a brief overview of Women in Global Health, which is a global movement of 14 chapters and supporters in 90+ countries around the world. So Women in Global Health is an organization that works with partners, chapters, and supporters to drive collective action around visibility and bring visibility to women experts working in health security. We're leading on thought leadership on gender equity and the health workforce through convening this Gender Equity Hub, for which Monia co-chairs. And we're also leading the development of gender transformative policy action for the health workforce with 100+ stakeholders through this hub. So today, as I open this conversation on gender and health security, just a few key facts. Women are 70% of the health workforce, but only 25% of global health leadership. Women also have a triple burden. So not only are they working jobs in healthcare, but they have the added responsibility of the COVID response now, and they're also providing the majority of social care to their communities and their families. In January, just 5 women were invited to join the 21-member WHO Emergency Committee on COVID-19. And as a majority of the global health and social workforce, women currently deliver healthcare to about 5 billion people. So women health workers are central to the response of any pandemic. Around half of all health workers are nurses and midwives, And as the International Year of the Nurse and Midwife is upon us, what better time than 2020 to harness the expertise and leadership of potential of nurses and midwives. So as we think now about how we can act to build better health systems in the future and support health workers, we know health systems are operating with our hands tied behind our backs. So we're excluding women in decision-making, but we know strong COVID-19 responses and responses in global health security draw leaders from the entire talent pool. Women health workers on the front lines of health systems don't want to be sentimentalized or celebrated as martyrs. They want to lead. We know they want to be listened to, and they want the means to do their jobs professionally, safely, and with dignity. So Women in Global Health has launched COVID 50/50, and this includes our 5 asks on a gender-responsive approach to health security. We ask that partners join the efforts to advance the agenda in your context and integrate it into your work. Gender should no longer be in the back burner. So often, you know, in conversations, we've been hearing that we are in a global pandemic, and gender equity is not something that's a priority. It's something that we'll tackle later. But the message that I want to convey to you today is that if not now, when? If not this pandemic, which one? We've been ignoring the gender dimensions for too long, and we're paying for it now. It affects everyone. So jumping into our 5 asks, the first is to include women in global health security and decision-making, and ensure that women's voices are heard in public discourse. So our ask is that WHO member states, international agencies, NGOs, and the media include women, particularly women from the Global South, as 50% of global health security decision-making bodies and expert groups. Our second ask is that we provide health workers, most of whom are women, as I mentioned, with safe and decent working conditions. This includes providing adequate personal protective equipment and procedures, and protecting workers from harassment and bullying in the workplace. Our third is recognizing the value of women's unpaid care work. So particularly those who are working to take care of elderly relatives, children, and the like, and including it in the formal labor market. For example, we have what we call home health aides in the United States, but this is not standard across the board, and often also community health workers are unpaid in various contexts. And so our ask is that this is included in the formal labor market. And this also includes paying women fairly for their health and social care work, and implementing family-friendly policies, for example, paid family leave for women and men, and helping to redistribute unpaid family care. The fourth ask is adopting a gender-responsive approach to health security data collection and analysis and response management. This includes collecting and publishing sex disaggregated data, and including women and men equally in clinical trials and other research. Conducting specific research to address biological and behavioral needs and risk factors that are different for men and women. For example, risks to pregnant and breastfeeding women, and also risks from use of tobacco and indoor cook stoves. For example, we know now that men are actually dying at higher rates from COVID-19, and you know, some of this can be attributed to tobacco use. So ensuring that we're gender disaggregating data, and conducting specific research to address the role of women in global health security solutions. For example, family and community health promotion, and impact on health policy of female decision makers, including parliamentarians. Another example that we've heard is that PPE is not designed for women's bodies. So often, you know, women are putting themselves at risk by having to remove their personal protective equipment for menstrual hygiene, and so ensuring that even down to the engineers of personal protective equipment, that women's voices are incorporated, you know, throughout this supply chain. And our fifth is funding women's movements to unleash capacity to address gender critical issues. So we ask that WHO member states, international donor agencies and NGOs, and philanthropic organizations fund women's movements, and particularly women's organizations in low and middle income countries, to unleash the capacity to address critical issues in global health security. So our opportunities to engage on the 5 asks, the first one that comes to mind is on Operation 50/50, which is actually a list that we launched with women of color in peace and security, WCAPS. And this list is a list of over 100 women who are global health security experts who are media ready and able to speak on global health security. And we launched this list because you know, towards the beginning of this pandemic, when we noticed that you know, there were commentators on the subject, we saw that there were fewer women, and so we wanted to ensure that media had no excuse, and so we crowdsourced this list of really renowned experts who are working in this subject area. And so the list is still open for nominations. It's on our website, womeningh.org, and we do ask that you continue to nominate women so that women's voices are represented in public discourse. The global health COVID-19 pandemic is a serious issue and emergency, which we cannot afford to ignore women's expertise and perspectives. And so we really appreciate everyone today for attending this event co-hosted by Women Deliver and Women in Global Health. And we hope that you will amplify these 5 asks and continue to nominate women in global health security, and do what you can within your sectors to ensure equal representation. Thank you.
Thank you so much, Sarah. And thank you for emphasizing the importance of women leadership in global health, particularly at times like these. A few housekeeping issues before we continue, just to mention that this session is being recorded and the recording will be made available later on. Also, please feel free to use our Q&A function to ask questions to all our speakers today. We have quite a lot of people on the line, and I do hope technology will not fail us, but in case it does, please be patient with us. Any issues will be resolved as soon as possible. So I'm going to go straight into the meat of the discussion, and our first speaker here is Michèle Boccoz. Michèle is currently Director General for Envoy for Multilateral Affairs at the World Health Organization. At the WHO, Michèle Boccoz is driving and strengthening the areas of health diplomacy, strategic engagement, and communication. Before joining the WHO, Michèle served as the French government's ambassador for the fight against HIV and AIDS and communicable diseases. While working with the French government, Michèle collaborated with many partners, including the Organization for Security and Cooperation in Europe and the United Nations. She was instrumental in supporting the international health regulations and emergency preparedness and response efforts. Michèle, specifically for you, women are 70% of the health and social care workforce, but they hold only 25% of senior leadership roles. We have seen women underrepresented in some countries in COVID-19 decision-making bodies. How can we persuade member states to value women's expertise? And can you tell us more about the WHO gender guidelines in this regard? Michèle, the floor is yours.
Thank you very much, and thank you very much for inviting me to participate in that meeting. And I'm really happy that we have an opportunity to discuss that. Thank you very much also, Sarah, for presenting your 5 asks. And I would first of all like to flag that in WHO, in the executive management team, Dr. Tedros has appointed more than 2/3 of his executive management are women. So I think that's a good example of finding the resources where they are and not saying that the pools are too small or that there's not enough diversity. I think that's a good way of showing that where there's the will, there's a way, and you can really push that forward. So I really think that health is of course, I mean, depending heavily on women. And as you said very strongly, it's only it's 70% of the workforce are women, but only 25% in leadership position. And as you know, WHO published a report recently, we called it, and that would of course resonate with you, delivered by women, led by men. But I really think that we have to make that change. And in the COVID response, we see so clearly that the women are in the forefront of the response, and they are in a sense doubly exposed, in fact, to risks for all the reasons that have been exposed. So we need really to make sure that we can really put them in a position where they are empowered and where they can deliver, and where their needs and their particularly how they can really be put in a position to deliver better. So as you know, health security and universal health coverage are for us the two sides of the same coin, and it's very important to think of it from a broad perspective, even when we are in the midst of responding to a COVID pandemic. There is no dichotomy between our response to COVID and the rest of the health system. So when we discuss the role of the health workers in the COVID response, it's an opportunity, again, to broaden our base, to think about the health and social workforce in general, and to think also about the issue of unpaid care response. Think about women economic participation, think about gender transformative policies, how to safeguard the health workers. And also you were saying we're not taking even into account women and gender in data. We don't have the proper information, so we really need to have better disaggregated data. What I would like to flag is our Director General, Dr. Tedros, recently said that there is no health without health workers. And we know that this is really felt across the globe right now, when everybody realizes that the very important employment, a very important job are coming from the health workforce, and women in particular. We know that there is an estimated shortfall of 18 million health workers worldwide by 2030. And we have been calling for increased investment in the health and social workforce. And what we are flagging really is that we need to have decent work as a key for health workers across the globe. So in order to attract more women into the health workforce, first and foremost, there's a need to be valuing the work of the health workers, what they do. And this needs to be met with sufficient investment in the health and in the social workforce. Clearly, job creation is a key, but these jobs need to be decent jobs, free from violence and harassment, jobs that are well paid and fairly paid. By that, I mean, it must be a gender neutral pay, and that have good working conditions. Gender responsive policies, such as paid maternity leave and flexible hours, are also extremely important. Health workers, as you very rightly underlined, have the right to decent and safe working conditions. And that applies really all the more to women who are, as mothers, are daughters, and are also having this role with the family. And so their role is doubly important from that regard of bringing indeed the healthcare to a broad range. As you know, COVID-19 is shedding a light on many aspects of working conditions for health workers, notably long hours, safety, and high workload. Fear and stress and burnout are some of the outcomes that health workers are experiencing at the moment. As they are at the front line of COVID-19 response, this aspect that you mentioned to protective equipment needs to be ensured in a proper way for women. So by offering women well-paid jobs and an equal share of leadership roles, we can accelerate universal health coverage, we can accelerate emergency preparedness, gender equality, but we can also accelerate inclusive growth. And the role really that women are doing, half of the women's healthcare provision is in the force of unpaid care work, and we really need to change that to be able to give value to what women do. So more than ever, it is clear that gender transformative policies are needed to support and advance women in the health workforce. We need to have gender parity in the leadership. We need to have higher female representation in policy making, positions, which remains low even in many of our global health agencies. Only 20% of the global health organizations were found to have achieved gender parity on their board, and 25% of organizations have achieved gender parity at senior level management. So, and we need to have more women in the decision making. That also influences the way that decisions are made, the way that the different needs of the populations are really taken into account. So we see that there is still work to be done to ensure that women are integrated into the global health security issue. This year is the 25th anniversary of the Beijing Declaration and Platform for Action, and we still see that there's a lot to be done for women health promotion as well, and reproductive health and sexual and reproductive health and rights. So we recognize that the need for addressing gender in all other aspects of health and well-being, including global health security, emergency, and preparedness, is very important. And again, it's so critical to recognize women's contribution to health and well-being through this health and social care workforce, and the ways in which the health sector can promote women economic empowerment through economic justice and the creation of decent jobs for women. So really, again, I think that we've made it clear it's delivered by women, led by men, and we must really change that. We must come to a much more proactive push into women playing the roles they are entitled to play in the health workers and in the health response. Thank you.
Thank you so much, Michèle, for that valuable contribution. And thank you also for bringing up the report delivered by women, led by men. Indeed, some very important issues came out of that report, and I'm so glad that you brought it up. There were 4 main areas that were recognized as needing special attention in us trying to achieve universal health coverage. And as you rightly mentioned, universal health coverage and health security are 2 sides of the same coin. Those issues being leadership, decent work, addressing the gender pay gap, and also addressing occupational bias. So I'm so glad that you brought that up. And thank you indeed, Michèle, for that very, very valuable contribution. This brings me on to our next speaker, and I'm going to invite Howard Catton to the floor next. Howard Catton has served as the CEO of the International Council of Nurses since February 2019. He joined ICN in April 2016 as the Director of Nursing Policy and Programs. During his tenure at ICN, Howard has worked closely with organizations such as the WHO to provide nursing advice on global health challenges, coordinated ICN programs and projects, and worked closely with healthcare-focused NGOs, CSOs, and private sector organizations. Howard is committed to ensuring that nurses have a seat at the highest level of decision-making for the benefit of the profession and global healthcare. Howard, the response to the COVID-19 pandemic will be weakened in many countries by health worker shortages. We've recently seen the launch of the Status of the World's Nursing Report. Can you tell us more about gender policy action in the field of nursing, which makes up the majority of the healthcare workforce? Howard, the floor is yours.
Hello, good morning, good afternoon, good evening. Delighted to be with you. Thank you very much for the opportunity. ICN has been privileged to work with both Women in Global Health and Women Deliver, and our President, Annette Kennedy, particularly asked me to pass on her thanks and best wishes to you all. For those of you who don't know, ICN, the International Council of Nurses, is the body recognized by WHO. We're in special relations with WHO to represent the voice of nursing. Our membership is of national nursing associations. We have over 130 from right around the world who are in membership. And the number of nurses and midwives globally, it's a new figure because we had just yesterday the first ever State of the World's Nursing report published by WHO, which ICN and Nursing Now partnered with, puts the global population at 28 million. Nurses and midwives comprise approximately 59% of the health workforce. And colleagues, just to share, I'm a nurse of something close to 30 years now as well. I wanted to say a little bit about both the work that we've been doing in relation to nursing in response to COVID, and then I wanted to say a little bit about the State of the World's Nursing Report and some findings from that, which I think are very relevant to the discussion today. And then I'll try and just draw 2 or 3 thinking points from that for you as well. Because we have national nursing associations throughout the world, we've been tracking and following COVID since the beginning of the new year. We have a very significant association in China, and as the virus has spread around the world, we've been following it and supporting and working with our associations. We've held a number of webinars with associations from Asia, from Europe, from Africa as well, all of which has contributed to, there's a significant number of updates and briefings on our website, free to download and access for the for detail for those who are interested. But just to summarize, there are 3 broad areas that we have been focusing our work on. Obviously, there are the clinical practice issues, good practice and technical guidance in relation to things like infection prevention and control, care of patients who've got COVID in hospital or in non-hospital settings, issues to do with, of course, with hand washing, very significant issues to do with mental health and psychological support as well. In addition, there's been a pile of work that we've been doing in relation to the public health and the health policy response, messaging, communication, importance of testing, social isolation, policies, and implementing those as well. And there's a very fundamental point, I think, to make firstly about ensuring that both the practice and the policy agendas are integrated. I don't think that you have good global or national policy if it isn't informed by clinical practice. I think there's a golden thread that needs to run through from practice to policy and decision making, which too often isn't there or doesn't exist. And one of the things that coronavirus has highlighted very, very strongly for us is that what those countries which have got significant nursing leadership at a senior level, part of the centralized coordination and management response plans from countries, are also countries where we see the response to coronavirus virus having been effective and starting to turn the corner in terms of the number of infections. But of course, a major area, a number of speakers have already mentioned, has been the protection and safety of nurses and the health workforce. From a very early stage, it was very clear to us in China that you run the risk of exhausting your nurses and your health workforce very, very quickly. People were working back-to-back shifts, very long hours, sleeping at their facilities, not going home. Just the physical demands of wearing protective personal equipment. Add on top of that the mental health and the psychological pressures that nurses and frontline staff were under. Obviously caring for people who themselves are anxious about how the virus will progress and how long their recovery may be, or if they're going to deteriorate, but also the very real pressures from nurses who were separated from their own families, not able necessarily even to hug their own children, or having family members question why they needed to go to work and to put themselves at risk in that way. And of course, the lack of PPE, the supply of PPE was an issue we first called out in February. Manufacturers weren't stepping up enough, and there were some real issues in terms of the coordination and distribution of supply, which required national and cross-national coordination. We were very concerned to see, though, that infection rates amongst health workers, nurses and health workers, was increasing. Sometimes it felt by the day we were seeing new numbers of infection rates, 9–10% in Italy of all infections of health workers. That was up at 13–14% in Spain. Very, very tragically, we've seen right the way around the world now reports of deaths of health workers as well, which we've said from ICN, we have no doubt that it's correlated, related to the lack of PPE supply. And when we've started to talk to our associations who are in Africa, where the numbers of COVID in Africa are similar now to how they were at the beginning of the pandemic in the Asia regions and the European regions, reports of nurses and frontline staff anxious, frightened and scared of going to work because of the absence of protective personal equipment. So we have again reiterated our call for nurses and health workers to be prioritized and protected. Their safety, their well-being is absolutely as important as the people that we care for, and it is not lost on us at all that 90% on average of nurses are women, and therefore disproportionately facing this higher risk. I think it's also our experience with the lack of PPE supply is starting to lead us to also to challenge the narrative that we're all in this together. And of course, there's an important public health message there in terms of our individual actions ensure our collective safety. But there is another analysis when you look at the people who are most protected, who are most at risk and not being protected in the health workforce, as I said, disproportionately women. But I think there's also, when you expand that to other vulnerable groups and you think about people who may be in atypical forms of employment, people who might be in flats or poor accommodation where they're unable even to go out, they have no garden so they can't go out for a walk, disproportionately it seems to us that women and vulnerable and marginalized groups are feeling the impact much more than others. Just this morning, we have released our own call to action, a top 12 priority list of what governments need to be putting at the centre of their preparedness and response plans. And I'm not going to run through all of that. It's available on our website, but it covers the issues of PPE and protection right the way through to collaboration and global solidarity. And literally in about 1 hour's time, we are publicly releasing a letter to G20 leaders, to all G20 leaders, that has been signed off by the presidents of the International Council of Nurses, the World Medical Association, the pharmacists, the World Pharmacists, the World Dentists, and the World Physiotherapists, as well, specifically calling on the G20 leaders to step up and do more to ensure the supply and coordination and distribution of PPE. Of course, it's great that we've seen clapping and applause for health workers, for nurses and for health workers, but we need to see commitments and action alongside the applause and the clapping, and we believe that global leaders acting together, looking beyond nation and country first, but multilateralism is absolutely key to saving lives, without wishing to be melodramatic about it, but that's the bottom line, that supply of this equipment will save nurses, women's and health workers' lives. Moving on then just to this State of the World's Nursing report that was released yesterday. As I said, it's the very first time that we've had a WHO report on the state of the world's nursing. That in itself, I think, is quite incredible that we've not had that before. It's also the first time that we've had a designated year of the nurse and the midwife by WHO. The report is entitled Investing in Education, Jobs and Leadership. But I'd commend you to look at the executive summary. It's fairly easy to access, because I think when you look at that, and if you look at it through the lens of gender, you can also see that this is a report which brings into sharp focus the inequality and discrimination that nurses in the nursing workforce have experienced for many years. I'm not going to give you every report, every statistic in the report. I was privileged to co-chair it along with WHO and Nursing and Nursing Now, which just meant that some of the figures really did resonate, and I even asked for some of them to be double checked to make sure that we were sure of the numbers that were coming through. I've said that the nursing workforce comprises 59% of the healthcare workforce, but currently the amount that we spend on education of nurses and midwives is 25%. It cannot be right that we are only spending 25% of global health education budgets on 59% of the workforce. I think there are conclusions to be drawn there in terms of why that might be, and nurses predominantly female occupation. We have a 6 million shortage of nurses. That's another standout finding from the report. That equates to, given the global population, over 20%. There is huge maldistribution in the number of nurses. So take an average as a pinch of salt, but 6 million on average is 21%. If you just think about what that would mean in your workplace, that you are permanently 20% plus short of the staff to do whatever it is that your work is focused and concentrated on. You know, what impact on your health, your well-being, your stress, your levels of burnout from permanently running at that level. And of course, we're seeing very clearly that we talk about a lack of preparedness, or we talk about fragile health systems. Strip away the euphemisms, and fundamentally that's about not having enough staff. Why don't we have enough staff given the pressure that shortages puts on nurses? And we know that the evidence clearly shows that where there are fewer nurses, the risks of harm, of untoward incidents, of patients dying increase as well. Again, I think it speaks very strongly to a history of not properly recognizing and valuing the work that nurses do. There's another very staggering statistic in the report. Only 30% of respondents said that they had measures in place to protect nurses' safety. That figure is even worse, because that 37% is based on 55 countries who responded. So if you assume, and it's an assumption, but the countries who didn't respond don't have measures in place, it could be as low as 20%. There are some statistics in relation to people, nurses reporting on their feelings of lack of respect and value that run around a third, 25% of sexual harassment. Clearly the long-standing issues others have mentioned in relation to lack of career progression, for getting into senior leadership roles. Strong theme in relation to lack of childcare, family support policies as well. And something that I think that I know speakers on this call have talked about, but we don't talk as much as we should about in nursing, and that is pay. I see woeful to frankly shameful levels of pay for nurses. We have nurses currently on strike in Zimbabwe because there is a lack of PPE supply, and they're fearful for their own safety. But those nurses are on 55 to 60 US dollars a month. We know from work that ICN has done that when global economic downturn happened, nurses' pay and salaries were hard hit and flatlined for a number of years. Obviously, we've got another global downturn heading our way. Pay is also important because it's a key driver to migration and mobility. Nobody stands in the way of the right of nurses to move around the world, but we have seen for some time countries who haven't trained and educated enough of their own nurses raiding and stripping those that are lower income countries least able to lose their nurses. The impact of losing nurses who move overseas can be that they're just not able to provide health services to those to their people. And pay is a really significant both push and pull factor in terms of nurses' migration. We've known about the migration issue for a number of times. We have a global code of practice, and we hear a lot of warm words around people who say they abide by the code of practice. But what the State of the World's Nursing Report highlights again is that actually high-income developed countries in Europe and the Americas, their reliance on migration from overseas has increased in the last 10 years, not decreased, not leveled out, even though we have a code. And we know that those countries that I've just mentioned, those regions I've just mentioned, have a higher age profile. 20 to 25% of their nurses will retire in the next 10 years, and they're not educating enough to replace them. So very significant risk that if they do as they've done in the past, they will continue to look to recruiting from other parts of the world. The world's nurses need a pay rise, but not, and I'm not saying that on the basis of some reward for managing and dealing with COVID. I am saying it on the basis that I think it's a very significant policy lever to address both the future recruitment and retention of nurses, and to recognise their true economic value as well as their professional, individual and social value. A couple of final wrap-up points then in terms of, I think I've tried to highlight how I see that gender inequality issues run right across both of the COVID and the state of the world's nursing. I think leadership is a critical issue. We still, the report, the State of the World's Nursing, says that there are around about 70% of countries who have chief nursing officers. I mean, I find it incredible that that's not 100%, but actually we know from ICN that you need to take a big pinch of salt with that 70% figure, because when we've interrogated it at ICN, you find that whilst a country may say it has a lead nurse, that person might sit at a more junior position, have no budget, sometimes isn't even a nurse. So even when you get a finding of, yes, we've got a position, we need to do more interrogation to make sure that those folk are at a position and have the authority and the resources that they need to do the job. A number of people have said to me, "Oh, isn't it a real shame, Howard, that we've got this special designated year of the nurse and the midwife, but it's been taken over by COVID, and your plans and your celebrations have all had to be put to one side." Well, yes, they have. The year is turning out to be very different to the one that we had planned, but everything that we wanted to achieve through having a year of the nurse and the midwife, to highlight the contribution of nurses and midwives, to bust some myths, to start to change thinking around value from just care and compassion to bravery and courage, to see the connections between our health, our individual, our collective health, but how intimately that is related to our economic prosperity and well-being. Beyond that, to our national security. I guess, even without being melodramatic, our ability to go for a walk in the park, I could argue, is related to whether we've got enough nurses, whether they're supported in the way that we would want to see them to be. So I think we need to still find time when COVID is over to celebrate nursing. But the coronavirus is demonstrating in a more powerful way than calling a year of the nurse and the midwife ever could, just how important nurses will be. The tragedy from this will be if we don't learn the lessons. The tragedy will be if we don't turn the applause and the clapping into high-level political commitments and actions. Thanks very much.
Thank you so much, Howard. I have to confess, I haven't yet read the report. I did manage to get my hands on it, but I'm very, very excited by it. And like yourself, I'm surprised that this is the first time that this is happening, but certainly very excited by this report and looking forward to reading it. I particularly like your points about having to link practice with policy, and I would almost add research and data to that. The need to linking practice, policy, and research are also so important. At the end of this, I'm going to be asking each speaker to give one ask in terms of policy action for us to make use of in our work at the Gender Equity Hub. And to be honest, Howard, I'm almost tempted to give you an ask for you, being 25% of global health education budgets only for nursing. I'm almost tempted to take over your ask, but nonetheless, I will be asking each speaker at the end of this to give one ask in terms of policy action for us at the Gender Equity Hub. So the next speaker that I have here is, who do I have next? I have Gvantsa, currently working as the Tbilisi city manager at the City Cancer Challenge Foundation. Gvantsa Khizanishvili is passionate about using technology for new collaborations and advocacy. She was born and raised in Georgia. She received a Master of Public Health degree from the University of Missouri at Columbia and received a Doctor of Medicine degree from Tbilisi State Medical University. Gvantsa is one of Women Deliver's young leaders, and since becoming a young leader, she's proud that her advocacy yielded an article in The Guardian about using technology for sexual health education for young people. Gvantsa, I'm going to give you the opportunity to give us your take on young people's contribution to fighting a pandemic such as COVID-19. Gvantsa, the floor is yours.
Thank you, Mwanya. And first of all, thanks for Women Deliver and Women in Global Health for organizing this webinar. I'm very delighted to be part of this discussion today. I would also like to thank and recognize women, especially those who are in the front lines of COVID pandemic and are also fighting cancer and helping to improve cancer care around the world. Currently, I am leading Tbilisi program at City Cancer Challenge, as you mentioned, and as far as those of you who don't know, the City Cancer Challenge is a global organization focusing on improving access to quality and equitable cancer care. And in Georgia, my main work is centered around using innovative, multi-sectorial and partnerships approach and the leadership to create solutions for complex healthcare systems challenges. And this pandemic, of course, puts new challenges in providing quality, equitable care for cancer patients, especially for women, since in Tbilisi, the country and with support of CCAN, Tbilisi prioritized breast and cervical cancers for this year to improve access to the best achievable care. With the pandemic, we're facing more additional challenges to realize those goals. As a background, today in Georgia, women are at the front lines fighting against COVID-19 virus. 62% of Georgian doctors and 81% of employees in healthcare and social protection sector are women. And most of the employees in the service sector are also women. Employed women earn 41% less than men and spend average of 42 hours on family work, 3 times more than men. And I think Sarah mentioned already global numbers, but Georgia is no different. Women who work remotely now do increased household chores and including closures of schools and kindergartens and take care of children at home as care for elderly family members. So there are additional, of course, challenges, many that I will not take more time to list. I would like to concentrate on the coronavirus, as coronavirus spreads, how this is affecting cancer care and access to cancer care in Georgia. We are, of course, facing multiple challenges, keeping the work for cancer patients open and running. Therefore, one of my work in this really crucial moment is to provide the most current information and resources to cancer patients, their families, caregivers, and the larger oncology community in Georgia, healthcare providers, to help ensure that individuals with cancer continue to receive quality care. And current recommendations have shown that the adults as well as children with chronic illnesses and conditions, including cancer, are at higher risk of developing more serious complications from COVID-19. Especially with some types of cancers and treatments such as, for example, chemotherapy that weakens the immune system, are at the greater risk. So we've learned that the patient and cancer treatment cycles are also an increased risk of infection. And some cancer patients are now in Georgia facing delayed surgeries and scaled back treatment as coronavirus advances. So we need a very fast response. Cancer care providers are playing a big part, of course. Providers will need to try new approaches to reduce the infection risk and patient time in the hospitals. Therefore, we really need to come together for the rapid response, and this for the at most risk groups, and rapidly evolving situation, to provide reliable information and is to the target population. And that has been one of my major works in this response to the pandemic. And we have as women and as healthcare workers, we have a really huge responsibility now to support our community and to support our health workers as well. And we need to stay really calm and connected and committed. Therefore, for the next couple months, we are leveraging our networks, local, international partners here, and compile a range of resources to support patients with cancer, their families, the caregivers, healthcare workers, like clinicians and nurses. Nurses are very important, and we have been working with amazing frontline nurses in Georgia. They have been just incredible in this response, and all the cancer care delivery team to ensure that the most accurate, up-to-date, reliable resources, evidence-based resources is delivered to the beneficiaries. So I think this is a very big responsibility that we are carrying, since the situation is also really evolving very fast. And the resources need to be updated on a very regular basis. And this has been a big gap, and that we are trying to fill in. We also contribute by trying to bring together and unite multiple stakeholders, physicians, patient groups, media, government, to work together to ensure that the critical work of conquering cancer continues during this global health crisis, and it doesn't stop. With that, I really want to recognize this has been a very, very special time for me, and I think for the health community here in Georgia and around the world, of course, is no different. And the incredible work of women in Georgia and the frontline people fighting COVID-19 and this global challenge. Meanwhile, fighting breast, cervical cancers in Tbilisi, and people who are working towards developing a rapid response, but also to think for future, for sustainable solutions for future in this type of situations.
Thank you so much, Gvantsa, for that valuable contribution. And thank you for reminding us that during this pandemic, a lot of health services indeed are going to be disrupted. During the Ebola pandemic, we noted that maternal mortality increased significantly, particularly in West Africa at that time. And it's one of the issues that we're going to have to face, unfortunately, as a result of this pandemic. During a recent CNN interview, Dr. Senat Fasaha also emphasized that a gender-responsive approach was the significant missing link to the global COVID response, and the reason being for a lot of the reasons which you have just mentioned, being that a lot of other health services, including sexual health and reproductive health services, will be disrupted. So thank you very much. Thank you very much for that contribution. At this stage, I'm going to go ahead and open up for a little bit of Q&A. Thank you again to all of our speakers. We've had a very interesting discussion today, and I think we're okay to open up for a little bit of Q&A and see if one or two questions. There's a lot of questions that are coming through, and I'll try my best to pick out one or two of them. And at the same time, allow me to take the opportunity to invite you all to join us as the Gender Equity Hub. As Sarah mentioned in her introduction, the Gender Equity Hub was established in 2017 along with the WHO, and it sits under the umbrella of the Global Health Workforce Network of the WHO. And our goal is to bring together key stakeholders to strengthen gender transformative policy guidance and implementation capacity to overcome gender biases and inequalities in the global health and social workforce. So I'd encourage you all who are on the line to join the Gender Equity Hub and become a member. And you can do so by sending us a quick email, or getting in touch with us. Our email address is geh@womeningh.org. So let's see what we have in terms of questions. I have a comment here from Carol Barton. Thank you, Carol, for your comment. When we do data disaggregation, we also need to count migrant women healthcare workers, and that's something that Howard had also brought out in his presentation. I think I just wanted to flag that. Thank you for that comment about the importance of considering migrant women healthcare workers, who are a large percentage of healthcare workforce in the current COVID-19 response. And this is Carol Barton from the Women in Migration Network speaking. I have a question specifically for Michèle. This question is coming in from Mumbai, from Namrata Ganari. Namrata would like to know from you, Michèle, the specific initiatives coming from the WHO towards gender equity, both outside and within the WHO, and how the WHO is edging national governments to achieve this. Do you have any specific initiatives to share with us, Michèle?
Thank you very much indeed. I think that's a very good question. So obviously there's a lot we can do and we actually do internally. And as I said, our leadership team is 2/3 women. I think that really makes a difference also in terms of how the rest of the problem is taken into account. And there's a very strong urge also and very strong push to include a lot more diversity in terms of recruitment. I mean, geographic and gender diversity as well in terms of recruitment for the positions that are open. And we really try to reach out. As our DG, Dr. Tedros always says, talent is really widespread, but we need to look for it. We need to look for it. We need not to fall into the usual patterns. We need to reach out, and we need to reach out to much more diverse groups and find the talents where they are, because they are there. And I think that's very important. Now, in terms of what can we do also to make this happen at country levels? I mean, obviously, we have a role in terms of pushing the governments to do that and inciting the governments to do that. And we do that through also our recommendations from our reports. And we quoted already the report delivered by Women Led by Men that really made a plea for that. But we're also putting into place concrete initiatives that we really think help also empower women in the health workforce and help them get to those leadership issues. And one of the initiatives which Dr. Tedros is launching, and he says it's really a game changer for him, is creating this WHO Academy, which is bringing together all our training activities from WHO and really change the way we train. Looking at competency pathways that would bring people to the level where they can play those roles, and women in particular. And I'm really a great believer that what we can do with that is also give many more tools, and we can have a very new, flexible way of training, adult learning, using the new adult learning, distance learning, using technologies that would also help women manage the time. I know it's more difficult for them, and really get to the level they can hope to get to. So I think this is also a very, very powerful tool to make sure that we also expand the pool of women that are on those pathways to these leadership positions.
Thank you so much, Michèle. I have a question here from Musal Musawi, and this is a question for Howard. Howard, you obviously spoke about the importance of nurses in our health, human resources for health. And I come from Zambia, a country which is very highly dependent on our nurses. Indeed, a lot of our establishments are manned by nurses and nurses only. So Musal wants to know from you, Howard, in most countries, nurses have low prestige, and because of that, they're starting to leave their professions. How is ICN supporting the nursing national associations? Howard, any comments?
Yeah, and thank you for the thank you for the question, because I think it's a really important one. The first thing to say is the importance of national nursing associations. One of the themes that has come out from the work we've been doing, the webinars that we have been holding, is that in many countries the National Nursing Association has taken on a really prominent advisory and leadership role to manage the COVID response. That may be providing nursing advice and expertise. In one place, it was being integral to setting up a 24-hour helpline call where new health facilities are being built very, very quickly. We see this right the way around the world, that the directors of nursing, the lead nurses for those establishments are very prominent, are important, but are also prominent in the media. We've seen in a lot of countries where ministers and chief medical officers are giving country briefings, that chief nursing officers are increasingly able to use that platform as well. So that connection between practice and policy is happening in a number of places naturally as a result of the response to of COVID, and we need to follow through on that after COVID is over, and saying, look, if COVID has demonstrated how integral that relationship is, how important that seat at the table for chief nursing officers, for nursing women leaders, for national nursing associations, if it's important in COVID, it's important to how we design, develop, deliver our health services much more generally in years to come. Another area of the report where I think that I didn't talk about advanced nursing practice. The State of the World's Nursing shows that we have advanced nursing practice in about 50% of countries. I think we're missing a massive opportunity with advanced nursing practice. The report contains, I won't go through it, don't worry, but the report, State of the World's Nursing, contains the evidence for how effective advanced practice roles are. They deliver great outcomes, patients like them, they improve access, and as well as being highly effective in terms of quality and care, they're actually cost effective. And I'm not framing this in a way that says, oh, let's go for a nurse model because we can't get the doctors, but actually medical profession is more challenged in some areas with aging than nursing is. So they're seeing the opportunities in this for new care models as well, that nurses could be absolutely forefront. And then behind all of that, let's just shift this rhetoric from as important and core as care and compassion is to really show how nursing delivers improved care outcomes, improved care experiences, and does that at a cost-effective way. That's not cheaper, and I'm not saying that, but get into the economic arguments as well.
I'm going to take one more question. I think this is quite an important one, and it's something that maybe we didn't speak about enough during this conversation, and that's around the issue of gender-based violence during a lockdown. Jabiri Esther has asked, how can we all help protect women and girls who are suffering from various forms of violence as a result of lockdowns in several countries? I don't know if Vance, maybe if you want to take that question, if you have any comments on that. Gvantsa?
Hello?
So the question is around gender-based violence for women and girls during a lockdown. Do you have any comments to make on that? Are you able to answer that?
Yes, thank you for the question. I think, yeah, this is the very, very important issue, and we have seen this in Georgia as well, and that the cases of domestic and sexual violence increased during the isolation. So I think we really need to put this issue in on the agenda, and not forget, as I said before, not forget that we have the responsibility to provide and continue to provide and do our work in the areas that we are serving. So I think at this point we really need to unite and mobilize all the organizations and all the resources that we have to mitigate this situation, and especially the non-governmental sector, and has to be very alert to not only provide the response in this COVID pandemic, but to unite the stakeholders and the media as well, to make sure that the voices of people are still heard, and the government does not forget that we still have the issues such as the domestic violence, the sexual violence. It's very unfortunate that we have been seeing that increasing in Georgia, and we really need to make sure that this critical work that we have been doing in terms of preventing and responding to the cases of domestic violence and sexual violence does not stop. We really need to make sure that we are still committed, we are still connected, and we are communicating and mitigating this situation.
Thank you. Thank you so much for those comments. And thank you once again to all of our panelists for a very, very interesting discussion. My last thing is just for my ask. I just want to go back to each speaker and ask for one comment in terms of policy action. What would be your most important? 30 seconds. What would be your one ask in terms of policy action? Michèle, I'll start with you.
Well, I think that what is so very important is really gender parity in health leadership. I think the ask is really to everybody to push for that outcome. I think that's what we need to reach. If we really want to make the world change, the way we consider women, the way we function also in the health provider, in health strategy, in health vision, in health services, I think that's what should ask. And I really would like all of us to focus on that and make it a key priority to move our agenda.
Thank you. Thank you, Michèle. Howard, you ask?
For me, it's all about the money. You know, whether it's money for education, whether it's money for pay, whether it's money for strengthened health systems, I think there's something about levels of resourcing that are clear and transparent, pinned to GDP, and based on needs, but as well as it's the money and it's the consistency. What we often see is that, you know, you might suddenly have a burst of funding or resources at a particular moment in time because the economy is doing better or there's political leadership which is particularly committed, but it's for a limited period, and then we move on to something else. And those periods of boom, of bust, of feast and famine result in these weaker health systems, you know, the lack of supply of healthcare workers as well. So lots of these issues for me go back to the money.
Thank you, Howard. Gvantsa, you ask?
Yes, thank you. I join my fellow panelists, and I think these are very important asks. And I think I also I was thinking about how we can have the more strong health systems that are more coordinated and to this situation, and to improved collaboration, multi-sectorial partnerships between different sectors, non-governmental organizations and hospitals and patient groups. I think it's important challenges like this, and we have really experienced now that there is a lack of that, and it's a big gap. So that would be my ask, to more communication, more collaboration, more multi-sectorial approach to health system strengthening.
Thank you so much. Sarah, I'll give you an opportunity as Women in Global Health to give us your ask.
Yes. So our ask is global solidarity and collective action. What we're seeing is, unfortunately, there is a wave of me first in some parts of this response, and as Women in Global Health, just really want to emphasize that collective action from all sectors, from all member states, is needed at this time. Also just wanted to briefly address the intimate partner violence question, because that's come up multiple times throughout the Q&A and also on the chat. Dr. Tedros released a statement from the WHO condemning violence, and just really sending a strong message that there's never an excuse for violence. And so our response to this is that we need to have a gender responsive approach. As Women in Global Health, we know that when there are more women in leadership, when we actually do have gender parity, when we are collecting gender disaggregated data, then we're much more equipped to be able to incorporate domestic violence responses into the global pandemic response. Thank you.
Thank you so much, Sarah. Unfortunately, there was one speaker that wasn't able to join us today. We were supposed to have Mr. Muda Baba joining us from the Democratic Republic of Congo, but it seems he's not been able to give us his take. Virtual engagement definitely has benefits, but it also, unfortunately, has limitations. So I'd like to thank you all once again for joining us, and I thank all of the speakers for their very valuable contributions. I'm going to let Susan Papp close our discussion today. Susan Papp serves as the Managing Director of Policy and Advocacy at Women Deliver. She's an award-winning advocate and policy expert with a passion for improving the health and well-being of vulnerable populations. Susan has nearly 20 years of experience working on global projects to advance political will, policies, and funding for a variety of issues relating to girls' and women's health and women's economic empowerment. Before joining Women Deliver, she worked with Rabbi Martin in the White Ribbon Alliance for Safe Motherhood in India and at GMMB. Susan, I'll give you the floor and I'll let you close.
Thank you, Munya, for that introduction, and thanks to each of the speakers who have participated in today's discussion. As we've talked about in the conversation, the COVID-19 pandemic is a truly unprecedented global health crisis that's forcing us to reshape our world. And women and girls are playing a key role in that reshaping of the world. And that's why it's so essential to apply a gender lens. The way that women and men experience these health emergencies is very different from each other. And that difference is rooted in gender norms and gender dynamics. As we've seen in past health emergencies, and as COVID is showing us today, health emergencies and pandemics exacerbate gender inequalities. We've seen examples of this playing out in COVID around the imposition of quarantines and the isolation that creates for women, and increased rates of violence and intimate partner violence. And I want to come back to the question that was raised during the Q&A about gender-based violence and provide some of Women Deliver's practical policy recommendations for this particular point. And that is, we encourage the advancement of policies that designate gender-based violence services as an essential part of health services. They are not up for question or debate in health emergencies. We need to ensure that women's shelters and centers stay open, that they're not converted into COVID wards. We need to ensure that domestic violence helplines stay open and operational. And we need to ensure that legal aid and critical services continue to operate and expand where needed, because the rates of violence are rising as a result of this emergency. We are also calling on first responders, health workers, police departments to be trained to recognize and respond to women and girls at risk and women and girls who are experiencing violence. You're seeing this in places like Spain, where women are turning to pharmacies to be able to report cases of violence. We need to ensure that those key social workers are also trained to recognize and respond to violence. Thirdly, when it comes to violence, we need to make sure that those who are responsible for protecting the public, such as police officers, are not the ones perpetrating the violence in the face of quarantines and curfews. We have some partners in Kenya who've reported increases in rates of violence, sexual violence and harassment from police officers as a result of women who are coming to and from work during the curfews, and that is simply not acceptable. We also want to ensure that sexual and reproductive health services are not curtailed or sidelined during emergency response. And we also need to recognize that migrant and displaced girls have compounded risks that they're facing as a result of this epidemic. In emergency settings where social distancing is quite difficult, they have a unique set of needs. As we've seen on today's webinar, there are many, many recommendations, and I just want to point to a slide that has some of them written down, and we'll just go over them. And this is if you have print screen functions on your computer, now is a good time for you to hit that print screen. So we want to ensure that governments must guarantee decent and safe working environments for all health workers. We heard this from many of the speakers. This includes PPE, but it also includes reasonable work shifts, providing access to childcare and mental health resources, and housing for health workers when appropriate, and ensuring that workers on the front lines are being paid adequately and sufficiently that would be commensurate with the demands of their jobs. Second, we want to make sure that we push social policies that push gender dynamics within the household to redistribute unpaid care and household labor, which disproportionately affects girls and women. And some of the speakers said unpaid care responsibilities are 3 times greater for women than they are men. And this number rises in the time of crisis. We have to recognize that women health workers often have families that they are responsible for caring for, and they can't do that responsibility of working in the health workforce and also shoulder the burden of caring for their families and loved ones, given the volume of demands on their plate. So how can we engineer and create social policies and social protection mechanisms to help them relieve that burden of unpaid care? Third, we want to ensure that sex and age desegregated data are top of mind for the World Health Organization and all of the governments responding to this crisis. In the context of the health workforce, it's critical to equip health workers and decision makers with that information that they need so that they can make informed decisions. Fourth, women must be included in equal numbers to men in COVID leadership and decision-making bodies. We know that when women's leadership in bodies and they have an opportunity to participate, it drives more inclusive, sustainable policies. And that is especially important for the COVID response in order to ensure that no one is left behind. Fifth, it's really important that we ensure that women's health and their sexual and reproductive health services especially are continued to be prioritized. As we've seen in past outbreaks like the 2014 Ebola outbreak in West Africa, it led to an increase in maternal mortality by as much as 65%. And this is because services were diverted. We need to ensure that funding remains constant and ongoing for sexual and reproductive health services, but also that supply chains disruptions are minimized to ensure that women continue to have access to contraceptives. So how do we make this happen? So turning to the next slide, please. So here we need to ensure that health workers' voices and demands are heard. This, as we all know, is Health Workers Week, and we want to be able to build and maintain this call well beyond this week. The Leaders on the Line campaign, initiated by the Frontline Health Workers Coalition this week, is one example of advocacy to do that and to amplify the voices of health workers and allies. You can find testimonials and share your own voice at #WHWWeek. Second, we need to leverage this crucial moment that the COVID crisis brings to take advantage of new opportunities to shape policy, and not only policies for today, but policies for tomorrow that can change the world that we want and make a better world for tomorrow. And this is where we need to ensure that decision makers develop plans and policies that not only respond to COVID, but that also help to ensure that universal health coverage systems and primary health care coverage systems are adequately funded and supported. Multilateral funds are being established right now, like the United Nations COVID-19 Response and Recovery Fund. And these present a key opportunity for push for greater investments that have a strong gender lens and health workforce lens. And one way of doing that is by calling on those fund developers to include a gender facility or to include a gender marker. And examples of gender markers are ways of providing analysis and recognition of how money and activities are being spent and apportioned, and it's a critical tool to track and monitor progress. Examples of this are the OECD gender marker, and there's also a UN gender marker, and the European Commission has an gender and age marker. So those are examples of resources that we can point partners to after this discussion today. Thirdly, we must ensure that governments, civil society, donors, the media, and other stakeholders apply a gender lens to their COVID-19 work. And this is especially important for health workforce. Fourth, we must ensure that actors across the age spectrum are meaningfully engaged in the COVID-19 response. As we've heard from some speakers, young people are some of those who are most affected by COVID-19 and what it's doing to their educational opportunities and the socioeconomic impacts that they will face long after this crisis is over. And they need to be meaningfully engaged in the response and the recovery efforts. Now is the opportunity to shift power, change inequalities, and disrupt patterns of exclusion. And finally, we need to ensure that investments in health workers include investments that support the needs and rights of girls and women in the health workforce, and that these investments are sustained beyond the pandemic and recovery phase. We've talked a lot about this on the call, and I think speakers like Howard said it best, and I'll leave you with what he said. It really comes down to money and resourcing. So those are the main recommendations on the how. I want to thank all of the speakers for joining us today. We at Women Deliver and Women in Global Health urge you to stay connected to us. We urge you to be vocal with decision makers at the UN, the WHO, and in your national governments to embed a gender lens both in the emergency response and recovery phase. As a final reminder, it's up to each of us to raise our voice and to join together in collective efforts to call for greater investment in the health, rights, and well-being of girls and women. In order to do that, we must support and protect health workers. Thank you very much.
Thank you so much, Susan. And I think you said it. I couldn't say it any better in closing. I think we're ready to close this discussion. It's been a fantastic discussion. Thank you, everybody, for joining us. Thank you in particular to our panelists for joining us. I know we're all very busy during this time, so thank you once again. I hope that we continue this discussion. I certainly know that we will continue this discussion beyond 2020. COVID is certainly going to be on our minds for a very long time yet. I would encourage you all again to join COVID 50-50 operation by Women in Global Health, to respond to the Leaders on the Line campaign by Women Deliver, and to join us at the Gender Equity Hub. We're particularly looking for in-country experience in implementing gender-sensitive policies and to drive policy discussion at a global level. So once again, thank you all for joining us, and please stay safe.